Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello listeners, this is Kevin MacPherson, and we are continuing our march through the interviews that we performed while on site at the 2019 AAOMPT Conference. In this case, I will be interviewing Tom Denninger regarding his presentation that was titled Pragmatic Application of Practice Guidelines in the Clinic, Programming High-Value Care at a National Scale. Now, before we dive into this interview, let's give you a little bit of background on Tom. He is currently a Senior Director of Market Research and Development for ATI Physical Therapy. He is also a faculty member for Evidence in Motion, which happens to be the group that he underwent his fellowship training. And finally, he is a graduate with his entry-level doctorate of physical therapy from Sacred Heart University. So without further ado, let's go ahead and kick into the interview. Before I get into the questions, Tom, do you mind just kind of giving us an idea of what you have done within your system, your health system or your company, that was really the stepping stone for creating this presentation?
Yeah, absolutely. The genesis of this subject really goes along the lines of we have a tremendous amount of discovery literature. We have great tools like clinical practice guidelines that help translate that literature. But when you look at large bodies of therapists and their relationship to the literature, are they really practicing within compliance or remotely around? There's a huge separation. You can step in any clinic and very quickly be like, I don't know exactly how I feel about that, either from a treatment selection piece or even just a dosage perspective. And all any physical therapist really wants to do is treat their patient the best way they can. So there's breakdowns in the implementation of the robust amount of literature that we do have. So my role within ATI Physical Therapy over the last 2.5, 3 years has been, how do we get this information to therapists? How do we set up systems that make it easier to do the right things than the wrong things?
Mm-hmm. Now, as part of your process, you've utilized different, I'll call them educational theories, but maybe not the right term. Like one thing that you bring into this is the Rogers Innovation Decision process. Do you kind of mind explaining that, how that played a role in what you're doing?
Yeah. So when we think about training, or we think about having a collection of people do something, a decision is made. Training is gone out, usually in one mode, an email, a PDF, a live training session, and then the expectation is everyone will now do this. And in reality, every single one of us know that that's not how this occurs. You have adoption curves of early adopters, your main group of people, and then your laggards. But really, I mean, if we think just from an educational perspective, you really only retain 10 to 20% of something that you read or hear the first time. So we joke a little bit about you need to go around the Blue's Clues theory. People need to hear things at least 5 times before they retain them. That's, for any millennials out there who grew up on Blue's Clues, that's the reason that they showed the same show every day for a week. People learn better with repetition. It becomes predictable. It becomes internalized. So when you look at the Rogers model of implementation, which is really one of the most prevalent theories regarding implementation science, which is really devoid within our professional evidence, really taking the things that we've derived, taking that randomized control trial and actually training people to do it and measuring whether they then do it. It's a system that's in place to show what I've always said, a high level of transparency. So you involve people in the decision-making process. Not everyone is going to get their way, but people feel in the know about why decisions were made and why those decisions are being made. And then it goes through a elongated process of showing training is not a one-time event. People need to be engaged in the training process. They need to be engaged in the decision-making process. And there is a consistent cycle of implementation, monitoring, refreshing, everything like that. Training is not an event. It is truly a process, and people get lost in that and have unrealistic expectations. And I think that's something I've had to monitor within myself, because I think we've all been in a situation where you send out an email and then you expect something is happening, and then when it's not, you say, but I sent you that email. And if you really view training as an event, you're just setting yourself up to be frustrated because you're not really giving people an opportunity to really think about it. It goes along with the idea that knowledge is never sufficient to induce behavior change. If that were true, no one would smoke, right? So it's about considering a holistic 360-degree approach about how do I make this change important for someone? How do I convince them that this is something that does apply to them, it is important for them to do, and it will actually better their life or experience by doing it.
So when I look at the framework that you provided in your talk, I do see kind of a concurrent ongoing training model. That ongoing training model uses motivational interviewing, which is something that you're alluding to a little bit right now, and I'll ask you a little bit more about that in a second. But I also kind of think about that time frame. We look at the research saying that a physician, mostly medical research, what they do in the first year of practice is what they're going to do throughout the rest of their career. Are you seeing the same amount of difficulty with a new grad hire as maybe you would see with somebody who's got 7 years out and now is coming into the ATI envelope when it comes to adopting these preferred practice patterns?
Yeah, it's very variable. When you think about young clinicians, for the most part, they're coming out with great academic knowledge. They're probably better consumers of the research than past generations of therapists, myself included, 10 years ago, 20, 30, etc. But their struggles are different. Their struggles are figuring out the systems within a day so that they can see patients and make them feel cared for and get their documentation done so they're not completely burned out by bringing 3 hours of documentation home. Or they're struggling with many of the interpersonal things that our patients respond to, the development of therapeutic alliance, instilling, confidence or expectation or clinician equipoise, things along those lines. So I would say for many of them, their actual familiarity with clinical practice guidelines is probably a bit better than some of our more experienced therapists. For instance, yesterday we heard Josh essentially teaches at Franklin Pierce and soon to be Tufts the orthopedic curriculum from the practice guidelines, saying if these are the standards that we're holding up and you really have that blank slate, tabula rasa, you can better instill some of these foundational things. But their opportunities for improvement go along with professionalization. With more experienced therapists, use the example of 7 years, but let's take that a bit more extreme to 15. Many of those people have those relational skills, certainly not all. Many of them have engaged in some level of metacognition regarding what has helped me in the past. What are the indications? We see that shift from type 2 to type 1 reasoning. But a lot of their experiential knowledge might not be completely in line with the evidence. Much of that has to do is human beings are not trustworthy narrators. If I think about my clinical practice, all of my patients get better because I'm very likely to remember my home runs. And I don't remember, or I'm never made aware of in certain systems, my strikeouts. So my thought process and theory about what works is inherently biased. So you might have someone who comes out and they favor, or they've been around for a while, and they favor a very specific approach. Let's call it McKenzie, for instance. Not to pick on McKenzie, super effective. But their bias is going to be, this works for every patient. And the fact of the matter is, it works for a percentage of patients, but it doesn't work for everyone. So how do we actually broaden your horizons a little bit, help you recognize where you have been successful, and help you recognize where your opportunities are?
So with that, I'm going to go back to the motivational interviewing. And there are certain things you look for the person saying that indicate what stage of change or acceptance of that part they play within the problem or the perceived problem behavior. Do you have like a process that you're assessing these clinicians, be it new grads or that 15-year vet, to put them into a certain portion of your training program within ATI, or is this just an ongoing thing that they'll continue to evolve as the research evolves? Like how does that look?
Yeah, it's a great question in terms of what we've been able to do with that knowledge. So motivational interviewing obviously comes from kind of public health promotion type research, has more recently been utilized within kind of pain science domains, which is really where I first encountered it. But the beauty of motivational interviewing to some extent is for anyone, a clinician, a clinic director, a regional operator, to say, how likely is this to change? What approach should I take and what should be my expectations for it? Because I think we have had the experience, if you're a clinic director, for instance, and your expectation is answer the phone. You're working with a clinical staff. Hey, the front desk person isn't always available to that. If you're available doing documentation, pick up the phone. And you get frustrated because you're particularly working with one person who is derelict in this responsibility. And if they are telling you that's not my job, or some very strong anchored language, it is highly unlikely that person is going to suddenly decide that part of now their daily responsibilities is answering the phone. And you can make a decision. You can say, that's okay. This person does a great job on other facets. Really, am I making a mountain out of a molehill? How often does this occur? I'm just going to kind of let that person be. You can take a little bit more of a proactive and potentially help them understand the implications of that, whether it's, hey, well, your teammates are doing this when you don't do this, that's potentially missing a patient that we could help, creating a value proposition that may be meaningful for them. Or you can keep beating your head into the wall and thinking that one day all of a sudden they are then going to decide. Very few people wake up and you go, you know what, I've been wrong. You've been telling me for 2 years that it's my job to answer the phone. And I woke up today and I decided that's probably something that I should do. Usually it takes some sort of transformational experience. Imagine a circumstance where that person missed an incoming phone call because no one was at the desk and it had real life implications for them. And all of a sudden they understand just how important it is. And this is obviously a very derived example,
yes.
and things, but just for the point of expression. So when we think about that in a large organization with multiple levels of management, there are certain things that we expect of people. We can be transparent with those expectations. And that can range anywhere from a clinical behavior to a certain treatment philosophy, to even just, how people relate to patients. And if someone has very anchored language where they're not seeing how it's their responsibility, or it's someone else's job, or that's not going to help my patients, or I think you're just doing this for money, any of those things, no amount of knowledge is going to convince that person otherwise. Mm-hmm. And really probably the worst thing you could do is lay into it and continue to, lay into that, because it's going to potentially result in the outcome that you want, which is that person leaving. And that's an extreme example and hopefully one that's best avoided. But keep telling people the same thing over and over and over and expecting miraculous behavior change when they are not in a position to learn or modify behavior as per motivational interviewing is running in mud. You're really not going to get anywhere, and ultimately you're going to get very frustrated. Mm-hmm. So being able to help train our clinic directors to say, when you're hearing these types of things, your approach shouldn't be lean in. Mm-hmm. It should be back off. It should be ask them the questions about what do you think happens when that doesn't, instead of just, you need to do this, you need to do this, you need to do this, because the need to do these just cement people. Mm-hmm. And make them even more reluctant.
So I guess I'm going to ask this question in relationship to what you just said, more about that leadership level. However, I can see it easily applying to someone at the staff clinician level who you're just trying to get to embrace the guideline practice.
Yep.
Are you guys using some of these simple tools such as that 0 to 10 scale, rate the importance of this activity, but instead of giving me the reason why you didn't rate it higher, give me the reason why you decided to not rate it lower, and then using that type of framework as well? I mean, how much are you extending motivational interviewing theory?
I would say there's a lot of opportunity.
Okay.
We've done it in a couple of key markets. We've done it in situations where people were struggling. It's certainly been in one-off situations that have kind of risen up to, hey, this person needs help. And it's one of those things, I don't know if we've improved the effectiveness of behavior change, but I can tell you we've definitely improved the life of the person who is trying to do the training.
Uh-huh.
There's some level of relief in terms of just like, okay, it's not me. And I think we feel that clinically when you're working with a complex chronic pain population. If you, for instance, are trying to use pain neuroscience education and this person is not being responsive, the frame or lens of motivational interviewing allows you some tools to potentially change that person, but it also gives you the perspective of, you know what, it's not me. It's not that they're a bad person. It's just not the right time. Other factors are, posing as barriers to actually change this. And I think that's conducive to an overall appreciation of people as a whole. A couple things that we tell our managers is that these are people. If there does seem to be some issues clinically, make sure you know what's going on outside of these four walls, because a lot of times people, to the best of their ability, leave that outside, be able to focus on their patients, but that will break through. So understand them as people, understand that other factors influence what happens in the clinic. And I think that ultimately gives an opportunity for people to feel better about the job that they're doing instead of feeling that they are ultimately ineffective in leading their team.
So not necessarily fitting with your talk, but I think it's valuable from an implementation standpoint across our industry. And obviously ATI right now with the work you're doing is pushing the envelope on this type of way of getting rid of a lot of undesirable variability in practice. It seems like you guys are actually using almost that same clinical reasoning process that experts use with clinical practice, where you're not just looking at that body of knowledge that you're gaining from the person in front of you in order to get to a diagnosis. You're also taking in a narrative reasoning approach. Like, let me learn about this person that I'm trying to guide. Is there like a leadership academy you guys are running for the implementation group, or what are you doing on that end to improve that? Like, this is fascinating to me.
We're getting better at it. It's actually ironic. I'll say this and come back to your original question. Putting together this talk, I realized how much we had done as one-offs and how it fit within an overarching structure, as opposed to starting with an objective and then developing tools and processes that fit within that. We've really taken a backward design in terms of, well, we need this for this and this for this and this for this and this for this. But hey, when we take a step back, oh my gosh, this actually looks kind of like it would if you had started with an overarching objective. We're still figuring out a lot of those things. Mm-hmm. We do not have all the answers by any means, but some of the core tenets that we want to focus on is we want to give people incentive to improve. So we want to give them actually visibility into their status. So we use risk-adjusted outcomes for our therapists, so they receive a clinician scorecard that shows basically their outcomes. And we don't want to give people raw outcomes because that's a little bit unfair. It's a very uneven playing field, so we control for things like age and socioeconomic status and chronicity and comorbidities and things like that, so you can get a true understanding. And it's not about measuring yourself against someone else in your clinic or region or state. It's how do I do within myself. So if you really look at the literature regarding expertise, very few people are good across the board. If we looked at your outcomes, Kevin, you might be really, really great at shoulder and knee and maybe not as good at spine. What we've actually seen, people are not extremity or spine based. There are many people who are very good at neck and absolutely terrible at the low back, and vice versa. But what we want to do is create an opportunity for discussion and introspection regarding, hey, what are the things that I do in these high performing areas where there's actually an opportunity that I might not be doing in some of these lower performing areas. And maybe it has to do with, well, I see these patients very frequently and I get good outcomes. These patients I don't tend to see very frequently. And it might not be because you schedule them differently. Maybe it's because the people that you're seeing less frequently don't show up to their appointments as often. Well, let's drill a little bit deeper into that. Well, they don't show up as often because you don't have as much confidence in that, and maybe you don't have enough confidence in it because you have some knowledge gaps, and maybe it's not universally a knowledge gap within that region, but you might be very good at acute low back pain in middle-aged men, but you have a very hard time relating to elderly patients, specifically the female gender that happen to have the pathoanatomical diagnosis of stenosis. So where's our opportunity for that? Well, we can certainly expose you to the literature regarding lumbar spinal stenosis. We can take some of the generic abilities type stuff and even actually train you to talk about what are not best practices, but what are strategies that have been successful in your clinic director regarding related to individuals that are significantly older than you. Because, I mean, when you have a 24-year-old therapist fresh out of school and they don't necessarily have a ton of exposure toward an older population, they feel very confident talking to 15 to 30 because there's a generational envelope there. But folks from a different, type of generation, they just have a really hard time. Well, can we talk about the Ford principle, right? You can have small talk with anyone regarding their family, occupation, recreation, and dreams. If you really want to offend someone, talk about pair topics: politics, the economy, abortion, and religion. You might get away talking about some pair things with peer patients, but is going to be very not good for patients of a different generation. So to your point, it's a clinical situation. Yes, when we think of performance improvement, what we've coached CDs to think about is think of it as a clinical situation. Look at your demographics, right? Ask subjective questionings. Far too much of our clinical coaching is me telling you instead of me asking questions. We really want people to have thoughtful, subjective conversations where our leaders and trainers are doing a lot less talking and a lot more asking. We talk about all the W questions except for why. Why did you do this? Why didn't you do that? It's very harsh. Where is the situation? When would you? All of those things so people can go on this process of self-discovery and say, you know what, now my incentive to change is because I do want to treat my patients well. I see that there are some things I do well here that maybe I don't do there. We've identified some reasons, and I've been central at coming up with this plan, as opposed to someone saying, well, you should take a course on this, or, you should figure out how to do that. Or when it's prescriptive, people don't invest, right? Because, well, if it didn't work, then that's your fault. Whereas if you have people involved in the process of making a plan for themselves, now they're much more likely to follow through because, well, if it fails, it was their fault because it was their plan all along. But we take a very clinical approach in trying to ultimately diagnose where someone's opportunity might be, and then actually approach treatment in a very similar way, knowing that people might have multiple impairments, order them, help them understand what they can do to help themselves before it's a matter of what you can do for them.
So the things that I'm hearing with this one, again, tie into your ability or what you've done so far with taking what you have learned from a clinical practice and apply that to training, apply it to implementation. Scorecard, when you talk about the scorecard, I think outcomes measure. When you talk about diving into it from their vantage point, I think of what we're supposed to do with an outcomes measure with the patient to figure out, well, why did you mark this the way you have it? So I think it's fascinating that you're using, perceived or not, you're using a lot of the things that were taught through fellowship and through enhanced practice as a way to change your organization in order to get better outcomes, which leads me to the next question. Have you seen, because Josh Cleland mentioned a few outcomes, a few clinical guidelines where when they actually put it to work, they were getting worse outcomes than what they were hoping for. Have you seen a improvement in the overall outcomes that you're seeing with patients yet with this program? Has it made those changes that you would hope?
So we're still very much in the preliminary process of this. If you really think of us being a finished product, but we're not in this process, it's really we've only had all the pieces there for maybe 6 to 8 months.
Okay.
What we actually have seen over that 6-month process is there has been a small, potentially significant improvement, especially when you look at a state level at our lower performing states or our lower relative to other ones. And that's probably where we concentrated a lot of our energy. So it's hard to tell how much, especially because we've been very spotty in rollout of the complete platform. I think a 2% change over 5 years is a very significant change. But I will kind of default and say we really don't know yet, and we're really invested in this being a learning experience. I can tell you how we're relating and training some of these things from 6 months ago are very different. I'll tell you that in 6 months, we'll probably have different ideas and make things better. But your continuous improvement process should be a continuous improvement process in itself. And the other thing about it is data never tells a whole story, but it also never lies. So all of our attempts at data have been trying to tell more of a story, but never only relying on that. So one of our big objectives for 2020, right now we're somewhere around 60% outcomes completion, right? We're very good at getting the first one. We're pretty good at getting a subsequent one, but one that would actually really qualify as a discharge score, maybe not, because a lot of therapists feel really good. Hey, at 10 visits, this person has done well, and they discharge at 13. And we really don't have an understanding of how those people did those last 3 visits. So potentially we're underscoring some therapists and really their effectiveness. So we're trying to make outcomes collection easier. We're trying to make it more objective. We don't think there is much opportunity for score inflation or falsehoods or anything like that, especially because there's really no incentive for it at this point. But we know as that becomes more and more a piece of how we are paid and how we are compensated and things along those lines, we essentially have to remove any of those potential just opportunities for malfeasance. So we're just always trying to get better in that so we can have more data to tell more of the story, and never eliminate the human piece of, so why do we think this looks that way? Well, it turns out that person, yada, 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 yada. Or there are going to be some people who might not score well, but they're hugely valuable people. They have different skill sets. What they are asked to do on a day-to-day perspective is not overly conducive to this particular measurement. But it's kind of one of those things. If you didn't measure it, it didn't happen. Go back to documentation. So another clinical parallel.
Yeah. So thus far, I've heard from you over the subsequent 3, if not 4 AOMPTs, you're going to continue to give us quantitative data on how things are evolving, qualitative for those N of 1s that show up, so that I look forward to learning more about how this process unravels, because one of my concerns as I evolve more into teaching is always the new grad being picked up by that large company. And ATI is a large company, and being put out kind of on an island. I mean, there's several that come out and they're the clinic director for this remote clinic. And I'm just thrilled that you and ATI have put forward an impetus to make sure that you are trying to up the game. And that's a big for our new clinicians, and also for those ones that we talked about earlier who are 15 years out looking to hopefully evolve. So
yeah, absolutely. ATI is big, 950 clinics and growing, but I think there is an incredible amount of investment in people's development. And yes, there are certainly situations, within the industry where, people are on an island and within 6 months now they're the clinic director and they've been devoid of mentorship and things along those lines. I also like to make sure that, we don't generalize those types of things, where even if that's something you've heard about with a particular company, that could be very isolated instead of thinking of it as a generalization. But I agree with you. New clinicians coming out have an incredible amount of load on them. They expect themselves to be really, really, really good. And the ultimate reality is very few of them actually have the potential to be, just because they lack the contextual knowledge and the not clinical skill set, but the professional skill set to navigate a day, a week, a month, things along those lines. So one of the things that we really are protective against is burnout, because we're seeing more and more clinicians, young clinicians, that don't realize that not everyone is going to get better. And they really internalize that. So we want people to be able to be the therapist that they want themselves to be, either from an excellence standpoint or from a specialty standpoint, things along those lines. But I'll take a push just for industry at large and large companies and say, make sure we're not making generalizations. I'm sure there is bad actors out there that are potentially putting these people in those situations, but it's probably more isolated than we think. And potentially those are the students or the young professionals who are pushing for more responsibility, and really the best thing we can do is protect them from themselves sometimes.
Yeah, and that's an excellent counterpoint. And every time I go into an interview, my hope is to expand my universe. So I do greatly appreciate that. So the last thing I have for you, Tom, is the question we try to ask a lot of our fellow interviewees. If you have somebody who's considering fellowship, what would you tell them?
Yeah. So just a little bit about myself. I graduated DPT school in 2008, immediately entered residency, and then immediately started fellowship after that. So I was a full-fledged fellow before the age of 26. And essentially I had made that choice for myself because I didn't want to mess around with trial and error. I wanted to do the right things early. I didn't want to hopefully learn from my mistakes. As I've progressed and understood more, I see the value of people having more experience. It's not that one is right or wrong. They are different and appropriate for different people. One of my considerations was, I'm young, I'm single, I can do a 80 or 90 or 100-hour work week, and I'm not hurting anyone, versus seeing people who have some years under the belt now, and then at the expense of their family or actually their overall health, undertake fellowship. So what I'll just say is make sure it's right for you, not just personally, because you might make the personal decision that, yes, I want to be a fellow, yes, I want to be excellent, but make sure it's the right time for you and the people in your immediate orbit. It's the best decision I've ever made. I consider my success as a clinician, researcher, any of these things strongly associated with my fellowship experience, but just make sure it's right for you and, more importantly, the right time for you and your immediate loved ones or other.
So a very insightful response. Tom, if we've got anybody listening who'd like to ask you more questions, what's the easiest way for them to reach out to you?
Yeah, certainly active on social media, on Twitter at Tom Denninger. Keep it pretty simple. Or feel free to email me at thomas.denninger, DENNINGER @ATIPT.com.
And with that, I'm going to let you get back to the conference. Have a wonderful rest of the time.
Appreciate it, Kevin. Thanks so much for the opportunity.
No, thank you.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.